conversations taking place, and I hate to cut them short, but I do want to try to keep us on time if possible. Before we start with the afternoon speaker, I would like to recognize Senator Del Colo. Would you stand, please? Thank you so much for joining us for this session. We always love it when our lawmakers take the trouble to get educated about these things, because we're counting on you to make good decisions for us. So thank you so much for being here.
Make some good laws.
Okay. Well, I'm very pleased to introduce our first speaker for the afternoon, Dr. Craig Jones. He's currently the Chief Medical Officer for Friedman Health and also under contract to ONC, Office of the National Coordinator for Health IT, as an advisor. He was formerly director of the Vermont Blueprint for Health, a program that was established by the state of Vermont under the leadership of its governor, legislature, and bipartisan healthcare reform commission. The blueprint is intended to guide statewide transformation of the way that healthcare and health services are delivered in Vermont, dedicated to high-value, high-quality healthcare system for all Vermonters with a focus on prevention. So, Craig, my new best friend, we spent all day yesterday together with Healthcare Commission and cast of thousands.
Thank you.
Great to have you here.
Thank you very much. So, first off, I want to thank you for the opportunity to be here, Dr. Walker, and Stephen Costantino isn't here, but it was, I think, on his effort I was able to come, and I really appreciate that. By way of background, the experience in Vermont was really an incredible one because Dr. Walker and I were just talking. I don't come from a policy background, and I stepped into a role with the governor to try and drive this comprehensive approach to delivery system reform. And it was quite a learning experience, but it proved to me that the transformation efforts can really work with the right leadership, the right vision, and the right commitment. And I just want to say from my discussions here, I think Delaware is well poised to do that. You've got a great foundation here and a real opportunity to drive a novel model for the country, as Dr. Brooks was pointing out earlier. Let's jump to the first slide if we can. So this is a quick schematic to give you, we'll get to the data and the information part of this, but the schematic helps describe what we were trying to do in Vermont with the delivery system reforms, because it's not about the data, it's how it's used and the impact that it has in causing real change across the state. So on the right-hand part of the slide, where we started from was advanced primary care. Call it medical homes, call it whatever the term is you want to use. We felt that was a key ingredient, as worldwide evidence has proven, to really have a value-based health system. So we set up a systematic approach to getting it's all voluntary, getting any primary care practice to go through the process of becoming an officially recognized medical home, meeting the requirements, and there's a very deep set of requirements to prove they're delivering the kind of primary care you need to have a value-based health system, going from access to guideline-based care to prevention to use of data to drive change. And so we set up a structured approach and ended up with about 147 primary care practices qualifying to be part of the program. And what that meant was, this is in 2008, it meant that they got additional payment on top of their fee-for-service. And they got an additional payment that was intended to give them more opportunity to reorganize how they run, to do more complete care, and to deliver better services. And all the insurers in Vermont participated in that, and eventually we got Medicare. So it was an all-payer initiative, and that's really when primary care was able to begin making a substantive change. I also show this to point out that it was hospital-owned practices, federally qualified health centers, and independent practices, the small ones, the ones and twos. It was made up evenly of virtually all the landscape of primary care practices, so it wasn't biased toward one or the other, and that was really important in the state of Vermont. The second part was getting all the insurers to pay for that big circle in the middle, the community health team. And what that was additional nurses, social workers, dietitians, community health workers, counselors, the real kind of support you need to take care of a population and deliver better preventive services. So from an insurer point of view, there were two payment reforms, one to the medical home, one to the community health team. The community health teams were organized and hired locally in each of the 14 service areas in the state of Vermont. There was one existing entity. We had a competitive bid that would hire and organize the community health team, but led by the primary care stakeholders and others in their health service area. And that set it up. And if you think about it, how else would you bring all these practices, the kind of support of social workers and nurses that they're going to need? You can't put them in every practice, but you could almost create a utility, a local fluid utility that would work within these practices and be able to flex and flow. So it became a core resource in each of the 14 service areas. Now the vision was that they would deliver better services, more comprehensive services, and they would connect people with the stuff on the left-hand side of the slide. The social services, the mental health services, behavioral health, economic services, that we would see a better integration because there was an investment in the people and better primary care. That was the hypothesis, if you will, in 2008 that led to the development of the model. It's still working in Vermont. It's foundational. It's statewide. Vermont is now moving to an all-payer model, a pretty advanced stage in the value-based payment model reforms. This is still foundational and woven into what they're doing. So far, it's worked out well. But what I want to draw your attention to is all the bars on the bottom, the stuff that often doesn't get paid attention to. The payment reforms are critical. You have to have the incentives structured that will allow people to work together differently. That's fundamental. We can put all the data and information in front of people we want. If they can't reorganize how they work and how they use it, most of those reports sit on desks and don't get used. So the payment reforms and very thoughtful value-based payment models are opening up space to do this. And I'll say one of my other jobs with the federal government right now is helping out with comprehensive primary care plus around the United States. There's 14 regions. I've been brought in as a subcontractor to help organize how they're using health information in these 14 regions. And the new payment model for primary care is driving exactly that kind of initiative across the country. Because of a new investment, because they're paid differently, they now can look at using information and organizing their services differently. So that's critical. The second is the transformation network. It's one thing to give information to whether it's a primary care practice or any other healthcare setting or any other health service setting or community provider. It's one thing to give them information. It's a very different thing to have that translate into effective change. So how you structure a learning network, a transformation network, the coaches, the facilitators, the shared learning forums is critical, and I'll talk a little bit about that. And then what we did was set up that learning network and did it by health service area, because for Vermont that was just a natural organization. There are 14 service areas and we organized it that way. And then lastly, the data infrastructure. What was going to fuel this thing? What was going to provide the information to drive it? So that's the framework we started with in 2008. Next slide, please. Let me just do, I promise there's only one of these architecture slides, and we were just laughing. Somehow I can't leave them out. I don't know what's wrong. But here's what we felt we had to do to begin to assemble the information that could really drive better performance, better care, better prevention. So I'll draw you over to the right-hand side of the slide. We started with an all-payer claims database. And when I walked into Vermont in the end of 2007, I was telling Dr. Walker this, there was an all-payer claims database almost unused. It was just sitting there. And I was like a kid in a candy shop, really. I can use this thing. Well, now in my work around the country, I can tell you, I can't even count the total number of states that have underused all-payer claims databases. And how you assemble the rules that allow the use of that all-payer claims database will determine its value. You are at the front edge of this. You have an opportunity to do this right. This is one of the most pivotal choices you can make. The wrong rules could really inhibit it. But we started with that, and we also had a health information exchange network, although not as advanced as yours and not as capable as yours. It's one of the real strong assets you have. we started taking data from our Health Information Exchange Network, bringing it into a clinical repository, a warehouse where we could begin to work with the data. They didn't have all the information. We would go to smaller practices and get feeds, and we'd bring that into the registry, and began to move the clinical data together with the claims data and link it, allowing for a more complete longitudinal view, more complete information about people. And then you can walk your way down the steps there. The next was the behavioral risk factor surveillance surveys. This is done in every state in the country every 2 years. It's not identified patient level data, but it can have a lot of predictive information about social and behavioral risk factors at a service area or a county level. And so we would bring that in to help with predictive information. CAPS is a patient experience survey done all over, there's different versions of them done all over the country, brought that in. And then as we built our opioid and addiction program, brought in corrections data to answer the question, are we improving health care and health outcomes for people with opiate addiction, but are we also reducing incarcerations? And right now, the Blueprint team is working on getting Department of Labor data in there too, so they can understand whether they're improving employment. So it was a stepwise process at beginning to build out data aggregation to provide more complete information to all the people that needed it to make the health system run. And as I was telling Dr. Walker, this was a program level build. We did this as the blueprint, and this is where you have an incredible opportunity in Delaware. We did this as the blueprint because we felt we had to. But the state didn't do it as an enterprise. It just wasn't ready yet. I think you're poised in a different place. And doing this as an enterprise build, leveraging the capabilities of your Health Information Exchange Network, leveraging the capabilities of your warehouse that you're working on in the state, leveraging those resources so you maximize the utility of this information, you're well poised to do it. The last thing I want to point out on this slide is the little loop back on data quality. We called them sprints. We fondly made this up in 2009 because most of the MR data coming in through our HIE was not in a very usable form. It wasn't complete, and there was a lot of gaps. Dr. Brooks brought up the example, do providers even know who's deceased in their practice? No, they don't know who's deceased. Not unless they happen to read it in an obituary and somebody recognizes it and then they go in and make a change in their EMR. So we've started taking files from vital statistics at the state and moving those in and being able to flag people so they weren't calling families to do outreach for diabetes for somebody who had died. So these kinds of things, there's a lot of data quality work, a lot of data completeness work that can be done. So let me move on to the next slide and go past this and get more to the use of it. So we did a lot of measurement, build it up slowly, a lot of quality and utilization. We started right off with expenditures and looking at total cost of care because that was an overarching priority for the governor and the legislature, that not only will we have upward pressure on quality and health outcomes, but downward pressure on the growth in healthcare costs. That was just a priority that we felt accountable for. So we started. You can't manage that unless you measure it. Patient experience. I already mentioned some of the social, economic, behavioral data. And one of the big things that we learned very quickly was the power of variation and the power of associations. Showing how outcomes and performance varied across settings. If I can leave you with one key learning experience that I had in this, finding insightful ways to display variation and then give actionable information of what's driving that variation is probably one of the most powerful things that you can do. Our products with the data, we put out practice profiles. Every practice got performance reports back. There were service area level profiles. We ran a whole network of learning system activities and gave them the information to help drive that. We had added on payments to the medical homes that were tied to performance, so there was an incentive to improve the outcomes and pay attention to a handful of priority measures. We evaluated the program impact. It felt this was a high degree of responsibility to the governor, to the legislature, to the taxpayers, that we were going to measure the impact of this program and every year display it, and if we weren't doing it right, they would know about it. Transparency, program impact was key. And then lastly, getting to predictive modeling. So you actually know who's at risk before things happen, and you can begin to do outreach and prevention. The boxes on the bottom are just some examples of the articles we published. We made a commitment to peer review publication using the data and proving program impact, modeling. It was a high degree to hold us to, but we felt that was important. And again, this is in the public interest. Not only that, it helped maintain the initiatives as governors change, as people come and go. If there's evidence that this is having a clear impact, it'll remain. Otherwise, it's more vulnerable to political transitions and to political change. So that was key for us. If we can go on to the next slide. Let me just draw your attention to one of those outcomes and to give you a sense of where things are in Vermont and the use of data. So I told you before, mentioned earlier, one of the things we hope that an investment in primary care and community health teams would lead to better health care, less unnecessary hospitalizations, more preventive care, less sick care, more preventive care. And we also hope that that would have a beneficial impact on costs. The top chart on the left-hand slide is total cost of care per person for everybody in the medical home population. I'm sorry, the bottom line is in our medical home. The dashed line is the one that for people treated in the medical home community health team setting. And that's the growth in healthcare expenditures with adjusted results, its whole population, commercial, Medicare, and Medicaid, over a series of years. And you'll notice that was growing slower than a comparison population, the line on top, which grew at a faster rate. That line on top, and it's important to assemble your data so you can have comparison groups and meaningful comparison groups. The line on top was Vermonters, all receiving primary care, but receiving it somewhere outside the program. Maybe they went into New Hampshire, New York, Massachusetts, maybe in Florida. They were getting their primary care somewhere else. And in fact, over years, and this has sustained, the total cost of care per person grew at a slower rate. That line is what kept the program alive over many years, the commitment of the legislature and the governor. But more interesting is on the bottom. Remember, one of the hypotheses we have was that by having the right payment models and incentives and investing in the community health teams staff, we would connect people to social and economic services better. The human side of services that people really need to begin to get at wellness. And this time you notice the lines are reversed. The people in the medical home and community health team setting on the top line had more utilization of special Medicaid services, transportation, home-based care, community-based care, education programs, dental. They used more of those services while in fact the people receiving their primary care elsewhere dropped off. And we had a whole series of analyses around this, but the fundamental idea that investing in better primary care and support services and all the other aspects of the program would improve healthcare patterns, but also improve use of social and economic services, improve people's overall wellness. And in fact, that has held true. Using your data, structuring it so you can evaluate program impact, I think is one of the most critical aspects that we found. We move on to the next one. The next thing is using it at the practice level and at the service area to drive change. These is some cover sheets from performance profiles that were produced for all the medical home sites, for all the health service areas. And what was done in this was production of a lot of measurement at a practice level, for example, showing them actually what cost of care was for their population, what drove the cost of care for their population, quality measures for their population, how often they were receiving recommended preventive services, some of the social and economic data, some of the clinical outcomes, the patient experience. It was a fairly comprehensive library of measurement that we could present to them in a way that they could use. And one of the key things they were able to do with this, and this is where I think you're going in the capabilities that you all have, is they could see how they compared to others, but then be able to drill down to what's driving it and make it actionable. And I'll give you an example of that. We can go to the next slide. So here was one of the simplest displays or visuals that we introduced early on, and it turned out to be one of the most powerful. And I only use it as a way to emphasize the importance of insights, doing a really good job with insights and visuals. Get your stakeholders together, refine the visuals so that for the providers and the others, payers, They're meaningful. They actually give them actionable information. So on this one, on the left-hand side, the y-axis going up and down is the total cost, is the actual expenditures per person using the claims data. This is how much was spent. Each dot is a medical home practice. Along the x-axis on the bottom is a total standardized utilization index. How much utilization there was per person in your practice. How many hospitalizations, emergency room visits, prescription fills, total utilization. And you can see when you first look at it, the more utilization you have, the higher your expenditures per person. That's not a surprise. That would be expected. But what wasn't expected was the variation across Vermont. And these are adjusted results taking into account differences in the populations and the practices. And you had tremendous variation even in a small state like Vermont with a relatively homogeneous population. Tremendous variation. But as was mentioned earlier about the cardiothoracic surgeons, if you were to talk to the docs and talk to the practice staff and the others, they're all sure they're running the best medical home there is. But the variation in every outcome was tremendous. And so what they could do is look in here, each practice, their dot would be red, it would show them where they sit, it'd show how they compare to others, and then they could move right down into what was driving it. Was it what they were paying for specialty care, for surgeries? Was it inpatient admissions for avoidable conditions like asthma and COPD and diabetes? What was driving it? And they could get to that, and then they could use their EMR to pull up their panels and work on it. So visuals, displays, and insights, and tying things to total cost of care is really important, and I'll give you another example of that right now. So here's another data picture, and it looks like a mess. It's a shotgun blast, right? What's on this, again, total cost of care per person on the y-axis, on the up and down. What's on the bottom is the most recent hemoglobin A1C result for each of these people. They all have diabetes. So this particular view is about 7,000 people with diabetes in the state of Vermont. Now, here's where picking your priorities and designing your incentives and your service models really counts. The national core measure for value-based payment models, the thing you have to do well on, is the proportion of your diabetics with a hemoglobin A1C less than 9. That's a national measure. It's in every value-based payment model that's coming to play. Well, if you look at this and you did a lot of work in your practice and you did outreach to all your people with diabetes and you brought them down to a hemoglobin A1C less than 9 on the bottom, it would have absolutely no impact on total cost of care in the same year. So you would not meet the goals of your value-based payment model. You would do a good job maybe at reducing hemoglobin A1C. That helps with cardiovascular risk and long-term health, and that's a good thing. But if you're really trying to also control the growth in costs, you need to look at something else. And that's what this type of data work shows. So this was very powerful because everybody was focused on diabetes. They all wanted to do outreach, get everybody's hemoglobin A1C down, do the eye exams, do the foot exams, all of which is good and would make no difference in your 12-month expenditures per person. So you dig into the data, and this is where your visualizations can really help. We'll go to the next slide. What do you learn? You learn that, in fact, it was all the comorbidities, the other things that people had that were driving the same year expenditures. So COPD raises your relative cost, your overall cost of care by about 1.8 times. If you have diabetes and COPD, just the COPD raises you up almost double in cost of care. It wasn't the diabetes in the same year, it was the COPD. So when you design your primary care outreach program, or when you're working to do better services, you go into your EMR, you have to do both, pull up your panel of both diabetes and COPD, bring them in, not only work on diabetes and hemoglobin A1C, but have a good service model for improving control of their COPD. If you don't do both together, they're not going to be healthier, and you're not going to have control over total cost of care. Does that make sense to everybody? A lot of this is intuitive, but it didn't change till you put the displays in front of people, gave them the results for their practice, and they could drill down and see, yeah, I have to do this. So this is coming out in publication, but it's an simple outreach model that shows if you do your outreach criteria and you search in your EMR by any of those combinations, which any EMR can do virtually, and you pull up the panel and work on the comorbidities with the diabetes, we actually have a predictive model in the paper about how much that'll save in total cost of care per year. That then becomes the basis for a value-based payment model. So this is using data, combining things with total cost of care that you may not think of otherwise, and there's all types of associations and insights that you can use to construct your work. Go on to the next one. And so this is a basic way of approaching it. And we're building this into some of the systems I'm working on now. Total cost of care on one part of the graph, some other important outcome index on the other. In this case, I put up a diabetes quality composite that includes 4 things that everybody wants to work on in diabetes. There's no relationship between cost of care and those. But if you can click on your dot, your red practice, in your visualization system, and instantly take it down to the results for your practice, show you where you are on each of those measures, you then can select and click on that result, and if we go to the next slide, have it take you right to your panel of patients and show how many avoidable hospitalizations they have, what's causing them, what's driving their emergency room visits. They can then take that information and do outreach and do better services. So you're linking performance on our priority measures directly into patient delivery. And when your social workers and nurses start calling and doing outreach, they're going to find out most of the time the reason the COPD or something else isn't well controlled probably has nothing to do with the medical care. It often has more to do with their social, economic, or life circumstances. But you won't know that unless you have the ability to outreach to them and begin to talk to them. So this is just a way of approaching the use of data and total cost of care, but having performance tied directly to improved services. The next thing is the learning network. How to actually make that culture change in data being used. And this was one of the fun things in the program. We had all our community health team leaders, blueprint practice coaches, and it's important to have coaches to work with practices that can help them understand and how to use data, drive continuous improvement. Our project managers, we had a network. Once the value-based payment models came in, the accountable care organization leaders joined us, and so it became a learning network. And it had a local one in each of the 14 service areas, and then we bring them together statewide on a monthly basis. And once they began to get these standardized comparative information and performance information back, and when their incentive models, their payments, were tied to improving those outcomes, they began to actually share their data. We didn't have to force the transparency issue. We never publicly exposed practice level data. That just wouldn't have been acceptable at the time in Vermont. We would publish publicly the service area results, but not the practice level. They would come into the groups, and once they began to get over the data denial stages and they began to work together, and now they entered into value-based payment models where they have a shared interest, they began to share their information and work together to improve outcomes. So there's a trajectory on the data use, and if we go to the next slide, for lack of a better term, call it the data use culture. And this is something that has to evolve. There has to be the right incentives. The information has to be meaningful with insights displayed. And so you make sure you have a stakeholder group that can help inform those displays that you're going to use the data for and really make it actionable. Actionable is critical. You provide information that directly supports care management for individuals, so that click from performance right down to outreach criteria. Provide information that directly supports outreach and prevention. One of the displays around the country that's doing that really well is gaps in care. When you open it up and you quickly see a visualization of the gaps that people have in their care and their preventive care, and it's a quick click to get the panels, that's very powerful and very useful. Display performance results that are linked to their incentives. There has to be some connection, and not just to one, not just to improving a quality goal or a health status goal. Those are important. But actually, to Dr. Brooks' original principle, do it big. You have to improve the total cost of care of the system at the very same time that you're going after these particular subpopulations and streams of work. And total cost of care is the common denominator across all value-based payment models. Highlight variation. There's nothing like feeding into, taking advantage of, leveraging the competitive nature. And again, when multiple providers are under a value-based payment model, they now have an incentive to work together to improve the outcomes. Leverage variation. Show people how they actually compare to each other. Otherwise, they'll believe that they have the best operations possible. Support the practices. End user support with coaches and facilitators is key. And in the most successful initiatives around the country, this is actually one of the things that we find was invested in well or not invested in adequately, was enough of a coaching support to understand how to use the information and how to change practice operations to do it. And then lastly, evaluate and report program impact. It will move toward a culture of transparency as people begin to work together and as their interests are tied together in value-based payment models. And if we go to the last slide, again, going back to the go big, take a systems approach. I don't think we can tackle everything at once, but you can tackle a lot. If you think back to the Blueprint program in 2007, all the different people that were involved in that, it was pretty adventurous, to say the least. All the major payers, commercial, Medicaid, and Medicare, all the primary care settings, all 14 hospitals being willing to support it, the community providers who all wanted the money to go to them and not necessarily to primary care. There was a lot of competing interests, and getting them to work together in a new way was a big challenge. But the key ingredients that I can pull out just on a personal basis, and I do see this from data around the country and the world, fundamental to a good health system is advanced primary care, but with the right incentive model, where they can actually change how they work. They can really help quarterback a health and wellness system instead of just function on a fee-for-service model. There has to be a way to have multidisciplinary support, the social workers, the counselors, the community health workers, and the dietitians to tackle the social, economic, and behavioral needs. They're often not there, but if the payment models are put together right, there should be enough room. And I would encourage looking at examples like CPC Plus, the National Demonstration Project. They're investing a lot to primary care for care management so they can have these additional staff and work. It's a change. It's a big change, but they're doing it. There has to be coordination with community providers, both medical, but even more importantly, non-medical. The silos there have to be broken down. And if there's incentives that are right to controlling total cost of care and improving health status, if that payment model structure is right, they'll begin to work more and more with the social services and the non-medical services in the community, because you have to. But you can't do that if your only incentive is to see somebody every 10 minutes. You have to reorganize that. Use health IT and data, both medical and non-medical. And states are in an incredible position. So I love to throw out the challenge. I tried it in our own state. States sit on all these incredible data sources. You've got Medicaid, sure. You also have data on housing. You have data on food. You have data on education. You have data on all kinds of social factors that are frankly just as much or more important in driving people's health and wellness. But almost never do states bring those data systems together functionally. So having a common identity management layer that functions across all those data systems so that Craig Jones is Craig Jones no matter which of those data systems, and they can be queried and linked to give a better longitudinal view of my record. Being able to do those functions and tie those data systems together to give more complete information is one of the interesting things that states just haven't done well. And yet, states are sitting on the data. You have an incredible opportunity to help lead the way. Now, that said, I'll turn around and tell you that in the work I do with other states, there are a number of states right now that are writing into their proposals to the federal government the capability to do exactly this. to extend those basic capabilities across their key data systems, so you actually can answer the question of, are we improving health outcomes? Are we reducing incarcerations? Are we improving employment for our opioid population? A basic use case that many places are interested in. So that's a big momentum target in the country, and you guys are in a place where you could do that. Adequate support for providers and practices to assist with transformation. That data use culture is critical, and tied to that is the learning network structure. So those would be just some of the key ingredients that seem to be emerging around the country, and we did see them in Vermont as well. And with that, I'd like to again thank you for the opportunity to be here, and happy to take any questions that you have. Thank you.
I do have a question, and work with the substance use mental health and youth. And my name's Erin. I do have a question when you're saying connecting forms of information, like medical examiners, delegates, I don't know, say the methadone maintenance programs. These are all systems of data, but I would want primary care physicians. But how would the primary care physicians know how to understand that information? And how do we keep integrity in who has permissions to what? And then what if a staff member of the government was in one of these data systems? How would they be treated? Or so I know I chose my primary care physician. So would you form a group of trusted primary care physicians and others? Because I know you said coach. I think coaching is really important too. So.
That's a great question. The question, I think, just to repeat, was really around two major themes. One, I think, is protecting people's personal health information and giving the right levels of access, if I heard that right. The second part had to do with just overall who would have access to these systems and concerns about trust. So a couple ways to approach this. First, take away the information about mental health and addiction for a moment. If you just talk about general health information, right now health information exchange networks all around the country are assembling data and exposing it to networks of providers. And actually, providers could look up people that they shouldn't in these health information exchange systems. But there are rules around that. And there's audit trails within these systems. And if they break those rules and audit trails, there's a serious risk. Now I'll take that example one more step. Every hospital you have, every health system you have in this state that uses an electronic medical record has their providers in the hospital or in their network. They could look up people they're not supposed to, but the organization has rules and it limits who they're allowed to, and if you break those rules, you're in a lot of trouble. So it's the policies and the rules that actually define how the users, provider users, are supposed to look up and access patients. And they're very strict, and there is audit trails. So that's actually how it's controlled all over the country, whether it's your hospital or whether it's a health information exchange. Now, let's say you weave in a more complicated aspect of protected health information around addiction, for example. This is a lot more difficult to manage for in many settings. And the way people are approaching this is to target limited controls, limited access, if you will, into who can visualize this information. So let me give you a non-Vermont example. The state of Maine has a really good health information exchange network, similar like you do. The state of Maine is taking in data from virtually every hospital and practice into their health information exchange. They then are taking in information from behavioral health centers. They're assembling it, sequestering it, and giving back what they call data-informed workflows back to the behavioral health centers. So far as the behavioral health centers, they're getting value of more complete information so they can work better and deliver more complete services. They, within 1 year, showed reductions in emergency room visits and changes in outcomes. And it was by assembling more complete information, packaging it with the right insights, and then exposing it only back to the people who were supposed to have it. So there are ways technically to control access. Then there's the rules of accessing information, which frankly apply across every setting in the United States. Those would be the two ways we can. Any other questions? Thank you all. Appreciate the opportunity.
There was one here in the back, I
Oh,
believe.
sure. Darn, I almost got out of here.
Health insurance play a role in what this is going on with the money. Regarding her question, with health information exchange, you able to drill down on data, that sort of thing.
How do the insurers or the payers participate, I think was the question in this. So in Vermont, they're one of the key stakeholders who have been at the table because it was a multi-payer initiative. And there were, all the typical challenges you would imagine with them. They, to date, actually have really gotten back our results, the Blueprint program, I don't run anymore, I keep saying our, the Blueprint program's results that they published went back to the payers, and we did breakouts for each of the insurers to show Blue Cross, to show Medicaid, what the results were in performance and how that variation occurred. So we gave them information back similar to what we gave the practices. But they weren't accessing, and still aren't, the health information exchange. Now, in other settings in the country, and I'm seeing this a lot in the regions with the comprehensive primary care initiatives, the data aggregators, if you will, the health information exchange networks, whoever's aggregating the data, are beginning to concentrate more and more on portals back to the payers so that they actually can get real-time actionable information about their populations, understand performance better, and use that to guide their work. So I think payer portals are coming into play more and more, but that's probably been a delay on that because people have been challenged with just getting the right information back to the providers and having it used. I understand here that your providers are using your portal and using it pretty actively, which is really a standout. That's not the case in many places around the country. So one of the key steps, particularly if you get all payer claims data linked together with clinical, would be to provide payers back with views that were meaningful to them. And how would you assemble that? You'd sit with them as a stakeholder and design it. What are the key things they need to see to help them with their reporting needs? And then I'll close with one example on that. One of the things that happened in Vermont was our payers asked the question, well, if you're assembling all this data, can you relieve us? You're measuring things. You're doing the learning network and quality. Why does the state require us to do quality initiatives on our own? It's just duplicate, and there's more people banging on the door of the practice. So the state of Vermont actually changed their rules and said if a payer was participating in the Blueprint for Health, they got relieved, if you will, of some of the requirements around reporting back to practices and data quality work with, and quality work with practices. That was a big administrative burden reliever for the payers. So if you sit and think about it, there's a series of use cases. This all comes back to business case, into use case. There's a series of use cases that are of value to payers, of value to providers, and the key is to define them and then assemble the insights that support it. Does that make sense? Yeah.
I was trying to draw the connection with, what is concerned about how do you get that information shared to the practices, and how do you make that connection, and what is allowable PHI information and what isn't.
Oh.
And so, yes, you can get it from the all claims paid data payables, but then how does that transform to the practice, and what's useful information?
I see. So the way things are emerging around the country, and this seems to be taking hold more and more, is whether it's clinical data from the HIE or claims data, or more ideally the combination of the two, they're being assembled, go through all the steps you got to do, the formatting, standardization, the identity management, and then they're used for analytics and displays. And what's coming out more and more is portals that providers and practices can use to look at real-time insights about their panel and their population. In most places, it's still a separate portal that provider groups are logging into. But as you provide them valuable information, the use of it is active, like it is here in Delaware. So I'll give you an example. In one state I work with, they're giving a portal back that can do exactly what I was showing. Their nurse coordinators or social workers can look up, see their performance on a particular result, click on it, and drill right to the panel that needs insights. So it's through electronic portals that they're providing. Now, in a few places where you've been able to really break the vault on data integration, some of this information is going right back into the EMR so that the clinicians can see it in an EMR. That interoperability is still at a immature stage. So most of it is being done through portals. And then secondarily, portals are being developed for payers now to do exactly the same thing.
Yeah, I'm afraid we don't have time for any more questions. We're gonna.
Okay. Thank you.
Yeah. So thanks very much, Dr. Jones. That was really helpful. Our next speaker is Dr. John Friedman, who is principal of Friedman Healthcare, LLC. John has 25 years of experience in performance measurement and improvement, health IT, care delivery, and healthcare reform. Before founding Friedman Healthcare in 2006, he held leadership roles at multiple innovative healthcare firms. Dr. Friedman served as the medical director for quality at Kaiser Permanente in Colorado and as medical director for specialty services at one of the Northeast's largest community health centers, overseeing 50 staff and 16 specialties. Dr. Friedman graduated from Harvard College, University of Pennsylvania School of Medicine, and the University of Louisville School of Business. Get around a bit. You and Dr. Walker should get together where you've got the like perpetual students of everything here. Friedman Healthcare is a leading healthcare consulting firm in healthcare reform, health policy analysis and development, and has been engaged in many states to create all-payer claims databases, implement health insurance exchanges, and support healthcare transformation. And full disclosure, Friedman Healthcare is working with DIN and our colleagues in the state to work on our healthcare claims database that was authorized by our General Assembly in the last legislative session. So we're really, really happy to have you here and look forward to hearing from you on total cost of care measurement and all-payer claims databases.
Thank you, Jan, for that very, very warm introduction. I appreciate that. Secretary, good to be with you. Thank you, everybody, for coming today. And I am here to talk to you about all-payer claims databases and to try to wrap it into the issue of total cost of care. And so I'm going to start off first by giving a little bit of background about all-payer claims databases first and some of the lessons learned in the states around the country that are working on them, and then from there go into the particular problems of measuring total cost of care, especially in an environment where an increasing fraction of payment arrangements are moving away from fee-for-service and into alternative arrangements. And if it's an all-payer claims database, how do you capture things that may not be claims? So with that, let's go ahead to the next slide. And so I think you all know this, you know, Delaware's got relatively high spending. It does not seem to have quality, at least by conventional measures, at the same level that its spending level is. So there's opportunities for improvement there. And through DIN, there's, you know, exploration of building an all-payer claims database. And obviously one of the strategic goals of all this is to be able to see, is there a way that you can now incorporate total cost of care from this? And as someone said earlier in this day's event, you really want to avoid building yesterday's all-payer claims database. So it's not going to be one size fits all. You want to move forward and make sure that it meets Delaware's evolving needs. Next slide. So let me start off with just a definition of what an all-payer claims database is. So it is an aggregation of some big data files, okay? And at its core, it consists of really three different things. It consists of eligibility files. That is a list of all the members, people who have healthcare coverage through one payer or another. So it has those folks in it and the type of coverage that they've got. It's got claims records. So again, at minimum, probably pharmacy and medical, but sometimes it's got dental and other forms of claims as well that can be included. And the third thing that it's got is a provider database. So it has to have a master provider database, the doctors, the hospitals, of course, but also the therapists, the home health agencies, the DME providers, everybody else. So that's all coordinated and put in there. Your neighbor Maryland was the first to go live with that as part of when they were going with their unified payment system there. But the first, what I'll call modern APCD, was only created, after 2003 in Maine, and that was what we would recognize today as one of these forms of being able to collect comprehensive information on eligibility, payment, etc. The important thing about APCDs is it allows for very, very diverse, flexible, sophisticated examination of healthcare system, healthcare spending. Next slide. As examples of that, and I will have some concrete examples to follow on some of these, you can examine many different things. You can start with public health. What's the incidence and the prevalence of various diseases? What are trends in disease treatment? You can look at performance improvement. You can use this as feedback data to provider organizations that they can use. You can use it to drive health policy. That's been a major use of APCD data in many states. To drive consumer choice, to get transparency out there, to have people be able to know what's the cost and quality, where should I go for care, and to support academic research. Next slide. And of course, today we're going to talk a little bit about benchmarking total cost of care. Next slide. So a couple of examples, we can move on to, we'll start with the state of Utah. So Utah decided to take a look at antidepressant use. So not merely prescribing, but the actual use based on who was filling prescriptions and who was using the drugs out there. And as you can see from this color-coded map, that even within the inset there, which is the Salt Lake Valley, there's wide variation in how frequently these drugs were being used. Over threefold variation from the highest to lowest areas of treatment. And it raises some very important questions. Is this because the incidence of depression is so widely different in different places? Is it because it's being diagnosed more often and more accurately in some places than in others? Is it that there is a problem with medication noncompliance, where some people are filling their prescriptions and in some areas people are less likely to? So again, this is sort of the first salvo of a bunch of incredibly valuable information on a major health problem for the state of Utah and of course around the country. So this was provided by the Utah Department of Health, and this went on to become the nidus of a bunch of additional investigations and exploration of behavioral health services throughout the state. We'll go to the next slide. Readmission rates. This is being tracked very, very closely now, of course, by CMS, and there are important financial penalties. But even before CMS started tracking it, 3 states in New England decided to collaboratively pool their all-payer claims database and come up with some tracking of what's going on. And you can see sort of across the midsection of Vermont and New Hampshire there, you see some relatively light colors where readmission rates are quite low. But you see other pockets of dark colors where readmission rates are high, and a variety of areas within the state of Maine, particularly more rural areas, where there's some very, very high rates of readmissions. So again, this is an area where you can not only be tracking quality measures and enabling these data for performance improvement and comparison, but even cross-state comparison across this entire northern New England region. Next slide, please. This one's hard to see, but this is a screenshot from New Hampshire's website, New Hampshire Health Cost. And what that has done is they were the pioneers. They were the first to really put up a price transparency website. You can look up a whole variety of services that you might want to get and find out what the prices are going to be. And furthermore, they can actually integrate that because they have the coverage information within the database. You can customize it to your actual payer. So if you've got Cigna versus Anthem versus Harvard Pilgrim, you can enter that in there. It'll tell you exactly what the expected payment amount would be across a whole variety of places that can do an MRI. And you can't really see it on there, but there's, again, threefold variation in the cost of that MRI. So again, as many people have high deductible health plans, or for that matter, if they're just caring about not having waste in the system, it lets you make a wise choice. So those are just 3 examples of how APCDs have powered innovation in different states. Next slide, please. And APCDs can be very powerful when you link them to other data. So, it's not an accident that Delaware's DIN is the organization that's exploring the APCD. And, this is frankly kind of cutting edge, because most states have created other entities to house the APCD that were not directly tied to their health information exchange, although many of them, and certainly all the progressive ones out there, have got very close formal and informal ties, including people from their HIE on the boards of their APCD, for example, and vice versa. But you can use it to link to a variety of different things, not just the HIE, but also vital statistics, as was mentioned earlier. If you've got a hospital discharge data set, sometimes there's additional data in there, and certainly a variety of quality data sets that can also be brought into this. Next slide. As a strategic approach, when you're building an APCD, we recommend that states go backwards. One way to do it, which is often not fruitful, is to say, well, let's see, who's the most famous one? You know, Colorado, they're getting a lot of press. Let's do what they're doing. Can we just take their data dictionary? Let's go. And that's not the worst idea in the world, but unfortunately it won't solve the Delaware-specific problems that you're setting out to solve. And so you really need to ask yourself, what are the problems that we're trying to get at? Is this primarily around consumer transparency? Is this primarily about understanding cost? Is this primarily about performance improvement? Based on those answers, which you develop through a multi-stakeholder process, then what you do is you create the principle to say, okay, here's what we want to get, this is the way we want to build it. If we need to get to there, what is it that we need to collect? How do we need to build this? Who are the people we need at the table today so that 18 months from now, we're going to be able to roll out what we want to roll out? Again, that's part of what this whole process is. So we've spent, frankly, a lot of our time, everybody calls us up because they want to talk technical stuff, and eventually we do, but we like to hold those off as long as possible and say we need to talk the other stuff first. You really need to get the politics with a lowercase p and the governance with a lowercase g. How are you going to do this? How are we going to make it work? Who's at the table? Next slide. Okay, there are limitations. APCDs are not perfect. For example, contrast it with an HIE. An HIE has got very, very timely clinical data. An APCD has got somewhat out-of-date administrative data. But the two are incredibly complementary. They've got different things. So you've got problems with timeliness. The bad news is that some medical claims take more than 90 days to come in, as you probably know. That said, the states that collect data monthly, they take any data that comes in that month. They don't wait for it to be 60 or 90-day lagged. And an increasing fraction of medical services, in fact, are billed more promptly. In fact, pharmacy claims are billed immediately at point of service. So those are, in fact, quite timely. Completeness of coding. You generally get very good information, for example, on a CPT code, because a doctor doesn't get paid in a visit unless a CPT code is indicated. But if the ICD-9 or diagnosis code happens to be incorrect, that doesn't really impact reimbursement. And so you have to be sanguine about when are these things which are going to be more accurate than others. You need to think about those kinds of things. Another one which I'm going to circle back to is alternative payment arrangements. So what happens when part of the payment is not coming from the claim of service? There's costs. These are not inexpensive systems. As a share of health spending in any state, it's a pittance. It's less than 0.01% of spending. But to a state budget that's trying to find the money and scrape the money together to support it, that is not an insignificant amount of money. And it becomes something important, and it's not an obvious revenue model. You can't just turn around and sell this and demand somebody pay you for this, out of a commercial market. So there are important considerations about sustainability and financing. Privacy has been touched on, I think, on some of the earlier ones, and clearly those are issues. I'm not going to touch on them in this talk, but those are important matters to discuss. And then comparability between states. Right now, there is no national standard. For a state like Delaware, that's small, and there is obviously some cross-border business, certainly with Maryland, with Pennsylvania. It would be useful to know that you've got some consistency of data collection. We're getting closer to that. We're not quite there. Next slide. All right, so let's talk about alternative payment models and how we use that to try to capture the total cost of care. So around the country, of course, under Medicare, Medicaid, and commercial payers, there are increasing models of going to ACOs and pay for performance, capitated payment, and other ways of having monies flow that are not fee for service. So we basically define an APM as anything that is not fee-for-service. And I'm going to concentrate in the next several slides on the state of Oregon, which has made considerable efforts on this because this has been a major objective of theirs, is to pull this in. So I want to give thanks to my colleague Tanya Bernstein, who actually pulled together these slides and is leading our Oregon project. So non-fee-for-service payments sort of come in two flavors as we break them down. Some of them are kind of dependent upon performance and are often made retroactively. So these may be pay for quality, pay for utilization, etc. And that includes things like shared savings, shared risk. You can't know about shared savings until the end of the year when you see if there are any shared savings. So these things are tied to the patients you see, but may come at different timings. Then there are other payments that are not directly tied to, a specific patient or a specific service, but may sort of come out, like a capitation payment. So there'll be payment, say, every month based on total membership. There may be other payments, sometimes called infrastructure payments, where we're going to give you some money to help finance an electronic health record that you're putting in there. And your organization may get X dollars that's going to come in to help fund that. It's independent of how well you do. It's independent of how many patients you see. It's just a lump sum payment that comes in there. And both of these types have to be captured in this process. Next slide. So there are a variety of challenges that we're seeing there. So, as I said, an increasing fraction of the dollars are non-claims based. They had a particular legislative mandate, and they had several bills and laws that really set up the APCD specifically to look at this, because this was of great interest to see. Number one, are alternative payment methods working? Are they doing what we want them to do? If people are in APMs, does it cost less? Does the quality go up? Is the access better or not? So how do we know? We need to capture these things, all right? And so they started building the system within the APC to do it. But again, these are not claims payment. In fact, some of them for the payer organizations don't even come out of their claims system at all. They have to pay it out of separate systems. So it's an entirely separate stream of data. Next slide, please. So the process started 2 years ago, okay? October of 2015, Oregon sat down and started to go through this. They identified and researched different methods for doing data collection. They went to make sure that they had the legal authority under existing statute that they could actually collect the data that they wanted to collect. And then they had to look at, how much was this going to cost and how difficult is this going to be? They obviously are a state organization. They need to make sure that they're staying within their own budget. And one of the things that they did very well is they convened all the stakeholders. So they got folks from the provider organizations who were receiving these payments, from the payer organizations who were both making these payments, having to deal with the bookkeeping on it, and negotiating the contracts around them, at the table to sort of make sure people had an understanding of how all this stuff works. Okay? They also went and looked at other states. And so they went around and found other states that were already starting to wrestle with this, and multiple states are doing it. And they came pretty quickly to the conclusion that they could not simply just copy a method being used somewhere else, because both the healthcare environment in Oregon is different than other states, and some of the purposes that they had in wanting to use these data were somewhat different than we're seeing in other states. And so they realized they had to come up with their own approach to doing it. Next slide. In the end, they actually ended up doing very, very well in figuring out how to make this work, and they learned some important lessons. One was that different payers categorize and classify alternative payment methods very, very differently. What one payer called P for P, another one was calling, shared risk or shared savings. And so they really had to come up with a common nomenclature and some very careful definitions just to get everybody to talk to one another. They also realized that there are different performance periods. Not only may they be of different lengths, but they may start at different points in the calendar. And so how do you deal with that if there's a retroactive payment being made for a given performance year, and that performance year doesn't line up with somebody else's? You have to learn how to deal with that. From the claims data alone, it is very difficult to identify which patients and which payments are associated with alternative payments. Most alternative payment methods now are what are sometimes called, fee-for-service and drag. It's a fee-for-service chassis, and at the end of the year, there's some sort of reconciliation about the final payment. So you can't just tell looking at the stream of claims coming into your All-Payer Claims database. Another thing is that although individual claims may be paid to individual doctors, individual hospitals, the alternative payment bonuses may be paid to a parent organization, a parent physician organization, a parent integrated delivery network. And so it's not always clear that the two went together. So it requires both some sleuthing, but then some careful decisions as to, well, how do I reallocate those dollars, that lump sum that went to this organization that was meant to pay for many constituent parts that had collaboratively earned those payments? How do we account for that? Okay. Let's see, some are tied to enrollment, some are not. I mentioned that earlier. But I think one of the key things was you've got to work really closely with the data manager. So, whoever is actually managing your data has to have very consistent, regular conversations and be on a very, very good working relationship with particularly the provider and payer organizations, so that there's a clear understanding of exactly how all this works and how it flows. Next slide. Again, I think one of these things, you've got to understand your data. This gets back to data quality. In any big data project, whether it is an HIE or an APCD, whether or not you're dealing with alternative payments, you really got to know the detail of what you got. And one of these things is you got to deal with situs, and that is what is the residence of the enrollee versus the location of the health plan that they're enrolled in. So, for example, a person who lives in Pennsylvania but works in Wilmington, Delaware, their employer will have them on a Delaware health insurance. However, when they get care in Pennsylvania, or even if they get it in Delaware, that may not be collected because they're not a Delaware resident. So you may say, we don't want to collect that data. Nonetheless, alternative payments may be made to those same providers in Delaware on behalf of that patient, even though that patient will be in one part of your data set and not the other. These all become questions that you got to expose, you've got to understand, you've got to learn how to work with. Okay. Go to the next slide. So here's where it ended up. They decided on an annual submission from each of the payers related to their alternative payments. The first submission just went in just a couple of weeks ago. So again, it was a 2-year process from 2015 to 2017 to get this all up and running. So they've got this data. They'll be kept separately. They're not going to just put it into the APCD. However, they're going to use it for these sorts of analytics where they're going to be attributing, if you will, those dollars from the alternative payment arrangements into the services rendered and recorded in the All-Payer Claims database. Issues with situs, as I said. And in Oregon, they have a particular interest in breaking that out by line of business, HMO, PPO, Medicare Advantage, et cetera, as well as understanding where's the flow of funds, particularly as it relates to primary care versus non-primary care, which is, again, a particular policy objective and very important for folks in Oregon. So, next slide, please. They're going to use it for a variety of these purposes. They're going to be looking at line of business. They're also going to be looking at, is it working? Are people adopting APMs, and are the APMs having those anticipated effects? Is the growth in costs falling? Is quality going up? What are the other things that we can measure? They also want to get an idea of what fraction of dollars are actually going into it. And I think in most parts around the country, even when there is a high penetrance of having an APM, the fraction of dollars in any given year that are actually tied, that are actually at risk, tends to be rather small. And so it's important to track how much, because that has a big impact on how effective any APM is going to be. And again, because of their particular policy interests, they want to know how much of this is flowing to primary care. Next slide, please. Where are they going next? Well, now that the data have been released, the providers are looking at it and are giving feedback to ensure the validity, the accuracy of the data that they've got. They are working on lining up APM categories. As I said, they'd had discontinuity between the different payers, but they're looking to adopt something of a national standard, frankly, through HCP-LAN. And they're looking at potentially doing other measures in there, working with their collaborative group that they've got going. And also see whether or not there's a variety of filings that are made by providers and payers in the state is there a way that if they're collecting this information that they could actually lead to some administrative simplification and reduce some of the otherwise mandatory filings that some of the actors in the healthcare system are required to make to the state. Next slide. I think that's it. So, the short situation is Oregon was able to pull this off, or so it appears. Again, they've just gone live. There'll surely be some problems that will be unearthed as it goes through review, but they came a long way. They came up with, in this very, very complicated environment, a means of successfully capturing APMs and therefore being able to calculate total cost of care. So with that, I'll be happy to take any questions that you all might have. Yeah?
What if you find that there are other states or other programs claiming the same individual, each individual will have an ID, so to prevent fraud, or if there's fraud found out, how will that be fixed, or who will that be reported to?
That is not yet really established. So if you're talking about going, so a couple of different things. First of all, identity resolution is a really important problem. It is in an HIE, as I'm sure you know, as well as in an APCD. And so when you hear, a patient, John Smith of Main Street, is that the same John Smith as another one on Main Street, or is that perhaps his father or son? How do you know? And when you see multiple things, so problem number one, you got to get at that. Number two, yes, you can use this to look for fraud. We're not aware of any of our clients yet using it for that purpose. And of course, if you can go cross states, there's the potential to be even more powerfully going after it. But as of today, nobody has yet made that use case. In the back.
So you're talking about total cost of care. How do you deal with user responsibility? Is that the kind of care claims database where we're all aware of our maybe deductible insurance amounts to get a population? From a patient perspective, it goes towards total cost of care. May not be how we are defining total cost of care. So how do we handle that? And how do we also handle self-pay patients? There is no clinical pay. That's not population out there. And then finally, how do you handle claims where the payer didn't pay the claim, so it's denied, whatever? Are those going to be captured? And what do you do with the total cost of care of those? Because the healthcare provider obviously had costs to provide that service, but nothing really
Great. So I have three questions there, and as I heard them, one was how do you account for the out-of-pocket expense by a patient? How is that captured? The second is for someone who's uninsured and is self-paying, where is that captured? And the third is what about a denied claim? Obviously, expenses were incurred in the system, but nothing may have been paid. So I'll take them in turn. So first of all, as far as the cost goes, the claims databases are generally set up to capture what's known as the allowed amount. So that is when somebody goes in, for a particular service, let's say they're going in for a routine office visit, the doctor may say have a charge of $150. The insurance company under their contract says, well, you have an allowed amount of $100, so there's a discount there. And of that, say, the patient is responsible for $25 out of pocket. All right, and they can calculate it using deductibles or whatever the means is. So even though the payment of $75 comes from the payer to that doctor, the system actually captures the fact that the patient was responsible for $25. So there is capture within the database of what amount was paid. Now, there's no guarantee. We don't know for sure that the patient paid their $25. It's sort of assumed that they did. Obviously, we know that whatever the payments are, it's never 100% of the patient allowed, but of the patient co-payment or deductible. Nonetheless, that is all captured in the data, so you can track all of that. So that becomes part of the cost of care. For someone who's self-paid, they're actually not in it because the claims that come into an APCD come from the payers. So if there's no payer involved, they're missed. So that is definitely a problem with the uninsured, and it's also an issue, for example, for non-covered services. So, cosmetic surgery, say, which is paid for by cash, or Or even sometimes people will prefer to pay cash for certain services. If they're going to go see a psychologist, they don't want to have a charge for that, they'll pay it out of pocket. Those are indeed missed. That's a relatively small fraction, and since the ACA, a declining fraction of care, but that's absolutely, to the extent that that exists, it's missing from an APCD. By the way, one interesting exception, the state of Maine, for their uninsured, they arranged with Blue Cross of Maine to issue ID cards to uninsured Mainers. And they would use those cards when they got service, and it would be adjudicated through the Blue Cross system. Nothing would get paid, but it would actually track the utilization. And so it was kind of a novel approach that was able to be used. Now, again, I think with the overall decline in uninsurance rate, that's less valuable as a mechanism, but there are actually creative solutions for getting at that. And then your third question, denied claims. Well, claims can be denied for many different reasons. So, of course, they can be denied because it's a non-covered service, say, in which case it sort of, may not count. So, I'll just use the cosmetic surgery. If I go in and I, get a cosmetic surgery and I submit it to insurance, insurance isn't going to pay. They're going to say, well, we're not paying that. Presumably, you're responsible for that on your own. However, there are other reasons why it's denied that you want to capture. So the APCDs typically have got a careful hierarchy of collecting data so that you submit it to insurer A, they deny it because they say I'm not a member there. And then the doctor's office called me, oh yes, I'm sorry, on January 1st I switched to insurer B. It gets resubmitted, it gets paid, that's captured in the system. Or sometimes insurer A will deny it because something's missing in the documentation, and then it gets resubmitted and then paid. So to the extent that claims are inappropriately denied, etc., it's a problem. To the extent that denials are only an interim step on the way to getting appropriate payment, they're not a problem. So that's a non-answer to your question, but it is to say that denials is an important issue, and you have to consider when it's really problematic to what you're trying to collect and when it's sort of incidental and a logistical matter along the path.
You had
No, go ahead.
you had a slide.
You've got the microphone. You get this.
Awesome. I'll just go on. You had a slide there with cost transparency, and it showed several payer examples. And my mind went to, I'm a consumer of healthcare, and would I have access to be able to say, okay, I want to go to provider A, B, or C for an MRI, and here's how much it is at A, B, or C, based on the particular payer that I might have as my insurer. Does it have that capability, and if so, do the payers have to release those negotiated rates with providers as part of participating in the system?
So to participate in the APCD. So typically there's sort of a balance there. So the state of New Hampshire, like most states, has a mandatory submission rule. So if you are a payer in New Hampshire, you must submit the data to the state, and the data will see to the penny what you paid for that MRI. So they know exactly what it is. As a general rule, the state's not interested in necessarily releasing that information to that very, very fine degree. So they'll often put out something and fudge it just slightly or round it off a little bit, which is, for example, what Massachusetts did. But it still gives you a very strong signal of where is higher and where is lower. And so, depending upon the state, some have said, no, we will not release any of that information. That's proprietary, and it's between the payers who may use it for internal purposes. But other states like Massachusetts, New Hampshire, Colorado are saying, no, this is important that we get it out there. We want to do it in a thoughtful way so that we're neither aiding and abetting antitrust behavior nor releasing more information than we really need to serve our purpose. But after all, if a consumer is responsible for this bill, don't they have a right to know? This question here?
I was just, you mentioned that it's sometimes difficult to find organizations or sources of revenue for this data once it's collected. Have you found any situations where you've been able to find sources or organizations that are interested in paying for this information once it's collected?
Yes, and I think So at least 2 states, Colorado and Massachusetts, have statutes that essentially say they should make their data available pretty much to anybody who has a bona fide reason for having it in a way that will improve the health of people in the state. In practice, though, both states, all states, are pretty conservative about being very careful not to release something that could be construed either as potentially exposing PHI or selling their data for something. Oh, you sold our data to a drug company? And I think we're still struggling to find the middle path there. You know, how do we release it? How do we protect privacy and yet make information available out there? I think the data, personally, should be made available to every provider organization so they can use it for their own population health management. As I said, it's a great complement to whatever data you have in an EHR. An EHR is great, but it doesn't capture any of the care that happens outside your institution. The claims data do. So there's a lot of good things that can happen, and we haven't quite gotten there yet. So I think that's one of these use cases. And I think the challenge is, what's the payment model for that, and how do we make it work? Everybody wants the data, nobody wants to pay for it, and there are a variety of models around the country, subject for another discussion that we could get into, as to what are the ways of building a sustainability plan around that. All right.
I hate to cut this off because some great questions and great answers. Thank you, John. And we do need to move on with our program today. So I'd like to introduce our final speaker. Karen Singh is Senior Healthcare Counsel in Massachusetts Attorney General's Office, where she directs initiatives to protect healthcare consumers, increase market transparency, and advance universal healthcare reform. Ms. Singh has more than 10 years of experience leading policy and law enforcement actions on behalf of Massachusetts residents, having previously served as Healthcare Division Chief and Assistant Attorney General at the AGO, as the first Policy Director for Market Performance at Massachusetts Health Policy Commission, and as a Consumer Protection Attorney and lecturer on law at Harvard Law School. Ms. Singh is a graduate of Harvard Law School and Harvard College, and we welcome you to the podium today.
Hi, good afternoon, everyone. So I have the privilege and the peril of serving as your last speaker today. My privilege to be able to synthesize some of the themes that we've heard from the terrific lineup today, and my peril to be standing between you and the rest of this beautiful day. So I'm going to try and keep this brief and think of it as 10 or 15 minutes of story time to close out your day. And it's a story about a little state to the north and some of our experiences struggling and navigating and negotiating and threading the needle on the very things that I'm very excited that are before you, and that thanks to Secretary Walker and all of the stakeholders that are gathered here today in this room, you're really going about this in the most thoughtful way, by pulling together thought leaders from all over to say, what worked, what didn't, what can we learn, how can we build a better mousetrap, and as Dr. Friedman said, build for the future. So next slide. My background, as you heard in the kind introduction, spans 3 agencies that have been key to our reform and our work in Massachusetts to address rising healthcare costs. Our Attorney General's Office and our Health Policy Commission. I've worked at both and led divisions at both. And then our Central Healthcare Data Hub, the Center for Health Information and Analysis, on which the board of which I serve. So from where I sit, I can talk across a spectrum of agencies that have been intimately involved in this work, culminating in 2012 in our own benchmark, which you see described on this slide. For us was setting this benchmark, which for 5 years was set at 3.6% 2% growth annually. Was this the beginning or the end? Neither really. It's been part of a journey, and I want to talk with you about the story of that journey today. Next slide. So the next couple slides, this one, and next slide please, show a lot of the complexity that underlies that healthcare cost growth benchmark. If you really want to measure total healthcare expenditures in your state, public and private payers, there are so many different market segments and there are so many different payers that it really takes a concerted effort. So if this was the result, if we finally in 2012, 2013, 2014, in the last 5 years, if we've gotten these 15, 20 disparate segments to row together to produce one number and to get at all of the different service categories, geographies, provider types underneath that one number for the state, what were some of the chapters of that story that made that possible? Why were we not ultimately, why was the process not sunk by sort of the inertia and the status quo, and what can be the overwhelming complexity of pulling together reliable, standardized, comparable data? Next slide. First, because the benchmark was not an end unto itself. It was one piece, as I said, in a journey, one tool in a toolkit, across a broader imperative, which is the healthcare transparency imperative. 50% or more of our healthcare delivery and coverage in this country is based on markets. And there's no sort of more foundational ingredient to a rational market, a functioning market, than having information for all of the stakeholders, all of the consumers, not just patients, not just residents, not just health plan members, but payers, providers, government, all of the stakeholders themselves. So we've seen, we, living in this country, have seen over the past decade a number of initiatives from a number of different angles trying to shed more light on healthcare costs and quality using comparable, standardized, actionable data. Next slide. So in Massachusetts, you can go back 20, 30 years. You can look at any piece of the Affordable Care Act and find that although we were the first state to do what we call Romney Care more than a decade ago, a lot of the precursors, a lot of the insurance market reforms that made that possible, all of the insurance market reforms that you see in the ACA that were done as part of one omnibus bill, it was really segmented out over 20 years in our state. And you see at the bottom of that slide, not at the beginning, but at the end, finally establishing a healthcare cost growth benchmark. All of the bullets and all of the milestones leading up to that event are just as important to explaining why the benchmark didn't fall flat on its face, why we were able to bring life to a paper mandate. So I want to direct your attention to some of the earlier bullets on this slide. I mentioned over a couple of decades putting in place insurance market reforms. What that did was strap ourselves to the mast. At the point at which we said healthcare is something that you have to go buy if it's affordable, the equal and opposite side of that coin meant doubling down and working to make it affordable. In 2008, 2 years after we passed Romney Care, we took sort of step one in a four-step journey. Step one was proof of concept. Have a way to show the importance of transparency and data, not in a wonky way, but in a very sort of real, accessible way for all of our stakeholders to kind of catalyze the informational infrastructure that I believe has underpinned all of our healthcare reform efforts. So that's the other bullet you see highlighted in green, which is asking probably an unorthodox agency, an attorney's office, a law enforcement office, to get involved in the business of healthcare policy. Next slide. So our Attorney General's office, like every other one in the country, does healthcare work. We were the first in the country to centralize it in a dedicated healthcare division more than a decade ago. That division does the same work that the Delaware Attorney General's office does in healthcare in other states. Law enforcement, oversight of the rules of the road. We also have, unlike some other AG's offices, unlike most other AG's offices, a really robust healthcare policy practice. We do monitoring, we do data investigations, and we release that information back out into the community to catalyze subsequent reforms. The legislature, in its wisdom, inserted a very short one paragraph into our cost containment law, asking the Attorney General's office to take a law enforcement tool, a subpoena, and apply it in a non-law enforcement context. And to date, we're still the only AG's office in the country that has that unique type of subpoena, compelling payers and providers to submit information to our office confidentially, to synthesize that information, and then to release it back out for, again, stakeholder consumption. It was novel because it's a very weighty authority. When you receive a subpoena, it's compulsory. If you don't comply, if you don't provide the data, or in our case, we also have the authority to issue interrogatories as well as deposition requests. So it's both oral and written information under oath. In that work, in more than, at the time, 10 years of litigating, that was the first time that I've ever received a thank you for a subpoena. And the reason was, at the point at which we have strapped ourselves to the mast and said, you gotta buy health insurance, we've got to make it universally accessible, a lot of folks had a lot of stories that they needed to tell with data about why healthcare costs were rising. But most of those details were bound up in contractual confidentiality between the payers and the providers. And so they couldn't tell others about it without violating their contracts. But if the government forces you and says you have to tell us, and we can keep it confidential and not call out any single individual, but make this a collective effort, that started to get the ball rolling. So you see in this slide what the one paragraph authority was, and the annual reports we've released in each of the 7 years since. And it's been a great pleasure to work with Dr. Friedman on these reports from the beginning. He served as our clinical quality expert. Next slide. So these slides will be available to the audience, so I won't go through all of our findings. But I'm really glad that Vermont is here and that we were able to tell a complementary story, because there were some very fascinating clinical insights that Craig shared with us. And the story in Massachusetts, the hidden story, was a lot about markets and prices. And both drive healthcare costs, right? Fundamentally, every industry comes down to spending is increasing because there are more units, higher utilization, because we have clinical inefficiencies, because we're not following best clinical practices, and or because the price per unit is increasing. And it doesn't matter whether it's a fee-for-service price, we call that an a la carte price, or it's a global budgeted payment, a prefixed price. That budget can be increasing, that fee-for-service price can be increasing in ways that aren't tied to value. So that's what a lot of our findings revealed. Let me give you just a sampling. Next slide. We call this one bugs on a windshield. What it plots is quality and price. So on one axis you have quality, and on the other axis you have price. This isn't my data. This is the health plan's own data. We have 3 major health plans in Massachusetts that together comprise 75% of our market. They themselves, internally, confidentially, wanted to plot the payment they were paying physician groups. So the providers reflected here are, a couple hundred physician practices across our Commonwealth. They plotted the price they were paying against the quality score of the physician practice. And instead of the nice sort of correlation that you'd like to see, or practices in the upper right-hand corner in blue, which are lower cost and high quality, you see practices, all over the map. So we weren't seeing that nice, relationship between, well, we're paid more because we're doing better. Next slide. We found that whether you're talking about a fee-for-service price or a global budget, this dysfunction and this disconnect between quality and level of payment runs throughout. So this plots not fee-for-service prices. This plots in blue the global budgets that our major provider groups are paid in Massachusetts. So we're one of the first states that has taken the global budget payment and plotted it across our entire Commonwealth. The height of the blue bar shows that for our major provider groups, adjusted for risk, adjusted for all of the variables that you want to control for so that you're comparing apples to apples. There are effectively a lot fewer dollars to care for certain patient populations cared for by certain provider groups on the far right of the graph than there are on the left. And the red bar simply represents sort of the resource deficit. So we're all in on global payments in Massachusetts. We're even extending them into the PPO population. But this is just, again, step one, proof of concept. Why do you need transparency? Why do you need data? How does it help you shape your policy in more meaningful and effective ways? Next slide. Pharma is all the rage, the hot topic nowadays. And in our most recent examination in 2017, we did extend our subject matter focus to encompass looking at pharma trends. And we were one of the first in the country that was able to look at pharma trend net of rebates. Simply, again, to put some guardrails on the conversation, because to the extent sometimes the rejoinder is the data aren't good enough and you haven't taken into account rebates, step one is take into account rebates, have a conversation, and see if trend is still something that we should be worrying about post-rebate. And you see those trends in the far right column on this slide. And our conclusion was, when you're looking at significant near double-digit or double-digit trend in 1 year, even net of rebates, it's still something that we've got to look at. Next slide. So step two, don't leave healthcare data transparency to an attorney's office or to ad hoc subpoena-based investigations. As we release these reports, the appetite among legislators, among payers, among providers, among consumer advocacy groups was insatiable. And what we ended up doing was helping to craft subsequent legislation, which are other bullets on that timeline milestone that I opened with, that routinized gathering of a whole spectrum of cost and quality metrics on a real-time, standardized basis so you can compare apples to apples across payers, across providers, and over time. And so you see a sampling of those cost metrics, like the allowed amount direct to consumers, but also all in relative prices and global budgets, which are designed for a different audience. Less for the patient at point of service and more for stakeholders who are designing more efficient healthcare systems. We have an APCD. We also have a corresponding database of provider affiliations. In English, that simply means which provider systems belong to whom. And as people have been going through the musical chairs of new affiliations and mergers and acquisitions, you need to keep up with that real time. And you cannot leave that to law enforcement investigations that are confidential, that build a one-time database that mostly the public never sees and can't use, and then the investigation settles, and then 4 years later you have to rebuild that database. So we have that real-time database of affiliations to marry with the all-payer claims database. And a set of standardized quality metrics. This one's still very much a work in progress. It has not reached the full potential that is written in paper, but it's a good reminder, it's not just cost metrics, it's also marrying it with quality, like Dr. Freedman said, and not having, how many providers are there in this room? How sick do you get of reporting a different set of metrics to each different set of payers, public, private, measuring A1C, but just a little bit differently than the next person? Step two is routinize that informational transparency and that tapestry that can help do, the three things you wanted to do. Put real-time guardrails on the conversation, evidence-based guardrails. help prioritize and locate the lowest hanging fruit, where there's easy consensus work to be done. And ultimately to incent behavior, because I mentioned that there is a very wide spectrum of consumers for data, depending on what type of data it is. It's a whole spectrum. And ultimately, it's not data for data's sake. It's not data to be on a shelf in a library. It's let 1,000 flowers bloom, and it's, you know, I'm happy to share offline some very concrete examples of how, in a way the legislature could never have anticipated, folks have taken that data and run with it and done very interesting and innovative things. So it's not data for data's sake. You've got to link data back to incentives, and the whole point is to encourage initiatives, pilots, innovation based on fact. And so to do that, you need to standardize both the cost side and the quality side. It's really hard to do innovation when you're obeying 100 different quality data sets. The process constraints on setting up your practice to check, cross the T and dot the I on endless different measures that don't talk to each other that's a type of friction into itself. That's not helpful. Next slide. So step 3 was taking that routinized transparency, that regularly released, regularly gathered data and regularly released data, and tying it to those carrots and sticks. It's linking data, not for data's sake, but linking it to incentives. So we have a series of carrots and sticks in our state that we've developed over the last 5 to 10 years. Whether it's a very market-based idea, like tiered and limited network products, let's try and steer patients towards the highest value providers, or whether it's something that's all in on clinical innovation, like patient-centered medical homes or ACOs. The idea is to take that routinized cost and quality framework and link it to these different incentive programs in a consistent, predictable way. Next slide. And finally, last step, having some sort of oversight monitoring infrastructure. You don't have to call it, our data hub has the unfortunate acronym of CHIA, so it doesn't matter what you call it. Probably aren't interested in borrowing that title, but we have sort of a triumvirate. We've got our data hub, CHIA. We have our canary in the coal mine investigator, it's the AG's office, and we have our health policy hub. And Delaware has all of the ingredients for that, all of the foundation, between the DID, between the Health Policy Commission and your other agencies to play that complementary role. Someone who's out there, the credible threat that there can be an investigation to keep the evidence-based guardrails intact, the data hub, so that you have that regularly released standardized information, and that connection back to a policy commission that has authority and integrity when it comes to the health policy development. Next slide. And I'll close just with some resources. Happy to take questions. I believe we've had to work really hard for this reputation. What I've heard time and time again is honest information broker. And that's sort of our, if we had t-shirts, that's our motto. And that's what we've been told, coined by others.
Run that kind of policy operation, FTE support and funding from the legislature. Is that a challenge in Massachusetts? Yes, it is, but to what extent
Yeah, it's a great question. You know, one of the lessons we heard this morning is you have to be able to, in a very succinct way, message the value proposition for stakeholders. So in most states, you know, in a large majority of states whose infrastructure I know, it ultimately comes back down to the payers and providers who fund kind of this healthcare oversight agency, where you have, you know, the states that have something extra that's, you know, more than just a health and human services, you know, cabinet level position, which is critical. So we've had our ups and downs in Massachusetts. Those three agencies, the AG's office, we've been very lucky because we play that canary in a coal mine sort of ad hoc role. It's, you know, it's a minority of the healthcare division. You know, we're talking at most total maybe 1 FTE across 2 or so individuals plus the expert team. So you're talking about a couple $100,000 on an ad hoc basis. Our dedicated agencies, the Health Policy Commission and the Center for Health Information Analysis, I think it's been really important to have boards that oversee both. Our legislature has been phenomenal in terms of getting it started, passing strong legislation up front. Once these two agencies were in place, we have gone through life cycles where there have been periods, you know, there was one period where I felt like our data hub wasn't as transparent to the folks that were paying for it as to the downstream patient, and that created some tensions and resulted in a stronger, more transparent board being put in place for that agency, and I thought that was really helpful. And I feel like that agency is in a good place.
We don't want to cut off any questions, so please don't hesitate to speak up if you have any. We're only just a few minutes past 2, so I think we could take 1 or 2 more. I think the crowd has been stunned. So I will wrap up the day. Thank you. To all of our speakers, I think it has been an incredible panel today of real experts who have brought us a lot of food for thought, experience from other states, good, bad, and ugly, and some things where we can learn from those who have gone before, but we also have some opportunities to do something really unique in Delaware that I think we're very excited about. So there is one more summit, I believe, on November 2nd on governance. So the details of that, I believe, will be forthcoming. And Secretary Walker, is there anything you'd like to say to wrap up the day? Okay, I guess we're wrapped up then. So again, thank you all for coming. Hope to see you on November 2nd, and drive safe and have a great day.